Thanks again for CIVHC's monthly Change Agent Chat. I'm Jay Wundt, and I'm CIVHC's Chief Medical Officer, and it's a pleasure to have you join us once again. Before we get started, just a few housekeeping items to mention. First, your phone lines are muted right now, and we'll be using the Q&A feature, the chat box basically, to field questions and allow you to make comments on the discussion. Questions posed will be answered during the Q&A. So we're going to do about 20 minutes of discussion, and then hopefully we'll have time at the end basically for any questions that you have as they come up during the chat. This webinar is being recorded and will be posted to the CIVHC website, so you may access the information again at any time without any cost. So we always start with this little preamble, but we keep using it. The definition of insanity, one person said, is doing the same thing over and over again and expecting to get a different result. In the case of American healthcare, that means if we don't actually change what we do, we're going to keep spending twice as much as our industrialized competitors around the world and get worse results. I'm convinced, though, that we can do better, and that the different and better ways are unlikely to come from some central plan, not ours, not Washington's, not anybody's. Instead, I think the real innovation in the 21st century is likely to come from the local level, and in particular communities where people find ways to work with one another across traditional boundaries. And indeed, when we at CIVHC looked, we found many Colorado examples. With limited resources, these change agents are starting to deliver on the promise of the triple aim: lower costs, better population health, and better patient experience. We're excited to bring these people to our stage so that we might all get smarter together. Today, we're thrilled to be speaking with Lauren Toll, PhD, Division Director for Integrated Care at Aurora Mental Health Center, and Margie Keems, a clinical social worker and program manager for the Hope and Health Wellness Clinic and the Mobile Heart Health and Wellness Clinic project. Lauren was responsible for the development and implementation of the Hope Health and Wellness Clinic, and she has more than 10 years of experience working in health psychology and integrated care for children as well as adults. Margie has been in the clinical field for 12 years and has extensive integrated healthcare experience across a variety of settings, including federally qualified health centers, bidirectional clinics, school-based health centers, and for-profit family practice. Aurora Mental Health Center believes that everybody should have the opportunity to live full and rewarding lives unhampered by mental illness. In 2013, they opened the bidirectional Chambers Hope Health and Wellness Clinic in partnership with their CIVHC partner, Metro Community Provider Network. The clinic is designed to serve adults, many of whom are clients at Aurora Mental Health, struggling with serious and persistent mental illness through integrated primary, behavioral health care, and comprehensive wellness services. Welcome to the show. Thank you guys for joining us today. We really appreciate you taking the time.
Absolutely.
Yes.
Thanks for having us.
So one of the first things that I wondered as I read through kind of the blurb and the profile is the term bidirectional. I mean, I kind of understand what that means in the generic sense, but what does bidirectional mean in your world?
Sure. So with bidirectional care, there's a number of different models of integrated care. Kind of the most common is really where you're putting a behavioral health provider in the primary care clinic to do screening, brief intervention, assessment, triaging people to appropriate levels of mental health care if they need that. Bidirectional care is really, I've heard of it called reverse integrated care, and I think bidirectional has been the term they've been using more frequently, is really putting the primary care services and embedding that in the behavioral health setting. We know that individuals with serious and persistent mental illness have high health disparities and are at risk for a number of different chronic health conditions, but necessarily see their medical home as being in the behavioral health setting. So this way we're able to meet their needs where they come more frequently, where they trust their providers and have an ability to access primary care services for their medical conditions, and then we can more easily share information between their mental health team and their primary care team. So information is flowing bidirectionally.
Cool. Yeah, so that's it's actually not a minor thing, right? Because I think people with serious and persistent mental illness have a life expectancy that's a couple decades shorter than everybody else, right?
Yes.
Yeah.
Yeah, and that's just because they have all this other stuff, or it doesn't get addressed, or both? How does that actually work?
It's a great question. So I think there's a number of things that play, kind of accounting for that health disparity. They die on average about 25 years younger or earlier than the general population. And Some of that is due to modifiable risk factors. So there are higher incidence of obesity, a much higher incidence of smoking, sedentary behaviors, and some of their psychiatric medications actually put them at higher risk for some of those conditions. Antipsychotic medications can impact weight gain, can put people at risk for metabolic syndrome. And so I think the primary care world isn't necessarily set up to handle that very well. And vice versa, I think individuals with serious and persistent mental illness have a difficult time, like all of us, navigating the healthcare landscape, and there's additional challenges that make it, particularly challenging. Their rates of getting preventive care or going to the doctor is much, much lower as well.
Yeah, so I've seen kind of examples of this model before. I mean, on the Western Slope, they have Marillac, and their motto is no wrong door. No matter what door you walk into, we kind of try to take care of all your needs, whether you present saying, I have this or I have that. They try to take care of all this stuff. This is kind of a national movement trying to actually propagate places like yours and Marillac's. In practicality on the projects that I've worked around the country, it always seems a little bit harder in practice than it seems in theory. It's kind of like, well, am I coming into your clinic, or are you coming into my clinic, or which documentation system are we going to use? What's your sense of that? I mean, it would seem in theory like this should be a kind of a no-brainer, natural thing, but it doesn't turn out to be that way. Why is this harder than it looks?
Well, I think a lot of the challenges are, as you mentioned at the beginning, Aurora Mental Health partners with Metro Community Provider Network, and it's common to partner, for different organizations to be working together. And we're structured differently, we're staffed differently, we use different electronic medical record systems.
Yeah.
Cultures are different, so it can make things a little more challenging. And so we work on building our relationships with our partners by regularly meeting, really proactively working on communication amongst each other and supporting each other in our goals, really making sure that we're talking a lot about how each organization's vision of integrated care looks and how we can make sure that we're working together to find a common ground and support each other's visions. But on the ground floor, from the program manager perspective, which is what I'm thinking about a lot, we have, fortunately, we've been able to get some grant funding over the years that supports additional support staff that the healthcare system doesn't necessarily support at this time.
Right.
That do a lot of back-end work around just reconciling medications in the system and diagnoses, and they also play a role of being a point person for clients to contact, so they can sort of help them navigate, so they're not kind of dealing with a phone tree over here and who am I supposed to call about this. And we're, as Lauren mentioned, we're in the same building, so it really helps that patients can come, and then people can help them find where they're supposed to be. They come to our clinic and they might be looking for a mental health service. I can help them go and find that. Or they might come to the psychiatry desk when they actually have an MCPN or an appointment at our clinic, and then they can help them that way. And we, as Lauren mentioned, we work so closely with the teams. Everybody in the building is really familiar with the services that we offer, just to support clients and helping them, navigate here. And since it's in one place, it makes it easier.
So I'm trying to envision, do the patients kind of shuttle back and forth between the two sides, or do you bring in practitioners from one place to the other? How does it actually physically work?
Well, physically, they do have separate appointments with their mental health providers and physical health providers. And the way that we work on bridging the gaps are, our teams my team members will go to team meetings with other programs and coordinate and discuss clients' care. And as I mentioned before, a lot of the back-end work that we'll do is we scrub charts the day before every primary care appointment. So it's probably about a 10-hour week time dedication for 3 primary care days where you see about 21 patients are scheduled.
Okay.
We'll huddle in the morning and we'll go over everybody on the schedule. So just anything that we need to talk about. Their mental health presentation, are they engaging in their mental health services? Is there something we need to do to support that? Did they go to their specialty care appointment? Does someone need to help them with that? Are they appropriate for the mobile heart health grant? Should we talk to them about this program? They've been wanting to get in the fitness center. How can we connect them with that? Go ahead.
Well, you used the term that I wasn't familiar with. You said you scrubbed the charts. What is that? What I mean, I'm envisioning kind of this brush, kind of go through it. But what is it? What are you actually going through the chart for when you scrub a chart?
So we're looking for. We actually have kind of a protocol and a list of things that we look for. Some of it's logistical, like is there a release of information in place so that we can talk freely about this client.
Okay.
We do have an agreement with MCPN, an organized healthcare agreement where we can share behavioral health and medical information freely, but substance use information is more strongly protected. But that's a kind of a common issue, so we just make sure we have that in place anyway. And then we'll be looking at medications and diagnoses and making sure that those are correct in the medical chart. So when the medical provider opens the chart, they'll know that all of the medications are listed that are prescribed by Aurora Mental Health and MCPN. And the mental health provider will look at the chart to see if they've been seeing a mental health provider, if so who, and is there anything acute going on right now that we need to know about? Like, was there a death in the family? Or is the mental health provider talking to them about something that we could support them with? I mean, we actually are really proud of how much we've sort of been able to promote integration at Aurora Mental Health and really support other therapists to be more aware of wellness. So sometimes, for example, recently we looked at a chart and the therapist is talking to the client about cutting back on soda. And that's what we do. But then it's great. So we know that and we can reinforce that with the client when they come in so they're hearing the same thing from everybody.
It's kind of stereo.
Yeah, yes. So those are some, I think that's probably the most of what we cover for reviewing the charts. And then our care coordinator will also look at, we can have that, we have access to university records so we can see if people have been to ER recently or have been hospitalized. Okay. And then if we're concerned that the person is really using the ER inappropriately, we can have a conversation with them and support them to manage their care, more on the primary care.
Yeah.
So.
That's awesome. So the one of the things I also noticed in reading the blurb is that health habits are a big deal for you guys. Actually, because from a kind of traditional medical standpoint, we oftentimes aren't good at that, and we're not actually trained in it. I mean, we don't do nutrition, exercise physiology. At least many of us don't in our traditional kind of medical training. Tell me about that and how you actually weave that into the patient's care plan.
Yeah. I think that is really critical and something that we bring to kind of the care that our patients, don't necessarily have access to at this point. As Margie said, I think we're shifting the culture around getting our mental health providers thinking about physical health goals, wellness goals. There's some concern about people practicing within their scope and feeling like that's not within my scope to touch on those, when in reality it really is. And so we train our medical providers and our behavioral health providers to think about kind of what are, the goals that this person has. Oftentimes the medical provider will have in their mind what they want the patient to start doing, cut back on this, quit smoking, do whatever. And, intuitively, I think patients understand that they should do that, and it's a lot harder than that. So that's where we can come in and provide some skills and strategies to set people up for success with quitting smoking. What's getting in the way? Why is it important to you? And tying those back to people's values oftentimes leads to more effective behavior change when they've got a buy-in into it as well and can identify why it would make sense for them. Sometimes it's really just taking that additional time to dig in more as to what barriers exist. And medical providers don't have time in their appointments to really take the time to do that. Example of that is we had a patient that was really was not managing her diabetes well, was drinking a lot of soda, and when our behavioral health provider went and talked with her about what kinds of beverages she could substitute with the soda, she said, well, I can't drink the tea I like unsweetened because I don't have enough ice cube trays. And that's not something that you would think about, but a really easy fix. So we were able to, get some ice cube trays for her and just very quickly provide some support to replace that behavior.
Huh, that's very cool. And I think oftentimes for medical providers, at least when I was in practice, we kind of thought, well, that would be a really good thing to do. I just don't have any means of doing that. I don't know how actually to affect that with the patient. So it's great actually to have the resource. So let's say I am seeing a patient that I think, they really do need to stop smoking, and it would be helpful if they had a regular exercise program. What do I do next?
Yeah, so in our clinic, we oftentimes try to set up the appointments from the get-go as really being a team-based approach. So for new patient appointments, our behavioral health provider will do a co-visit with our medical provider and actually sit in on the visit with them.
Cool.
Kind of creates a couple of different things. It sort of sets the stage that this is an integrated clinic and we are working together on, improving your health. And the patient's a part of that too. So they're, part of the team as well and deciding what they want to work on, focus on first. And then, we're not also asking them to replicate or, repeat everything that they said to the medical provider. We're hearing it directly from them. We're hearing directly from the medical provider what advice they're giving. And then we have a way to kind of launch into, so you have identified that you want to quit smoking and your provider wants you to lose weight. Where do you want to start? And we can kind of use some motivational interviewing techniques to see where they're at in terms of their readiness to change on those things. We have currently a number of different wellness groups and strategies we use for folks who are wanting to quit, to lose weight. So we have an evidence-based group that we do that was designed from Kaiser to focus on individuals with serious mental illness. It's a 24-week kind of group getting really into the nuts and bolts of strategies to recognize what's in your food, to replace those with other things, to be more aware of what you're eating. And then we also have an on-site fitness center and a personal trainer who operates in a very trauma-informed way so that she makes people feel comfortable if it's their first time starting an exercise program, doing it safely in a safe space. And that reduces a lot of barriers that people have to affording gym memberships, having a safe place in their community where they can work out. It's available for free here for them, and that's another way that we can offer and support their wellness.
Great. So as I told you before, this always runs really fast, and I never get into as many questions as I would like. Let's just talk about results before we kind of take questions from the audience. How do patients like it? How do your providers like it? And then this is the Center for Improving Value, so we need to talk about, have costs come down for people who participate in your program? Tell me about all three of those things.
So yeah, in terms of provider satisfaction, actually, I was asking our medical provider more about her experience working with us. And, she said that it really struck her when she started working in our clinic, the level of complexity that our clients present with. I mean, frankly, I think she used the word, it was just astounding to her.
Yeah.
But she really, really loves working with the population. And she also talked about how invaluable the support that our team provides for her, how much it makes her job possible, and the patient experience to be that they actually get the support and services that they need to address their complexity. That piece of satisfaction. And, our team is really close-knit and works really well together and has a lot of fun and works really hard. And it's actually a great environment, and our clients have really seen us as a place for them to come, and they know that they can stop in any time and ask any questions that they need. And some of them even, like, for example, we had one client who, unfortunately his therapist left the organization, which happens sometimes, and we've sort of become his point, support that he can go to, that he feels comfortable with. So that's neat.
Yeah.
Yep.
And in terms of cost, through support from CIVHC and the APCD, we've been able to access some claims data for our population just to see what things we've been able to, incur. And it's been pretty interesting to see our clinic started right around the same time as Medicaid expansion. And so we benefited from having a lot more people with a lot more claims. Prior to that, some people didn't have access to primary care services or weren't accessing them because they didn't have insurance. And so what we've seen is for those that were utilizing the ER at high rates, or kind of our higher utilizers, after they were in our program, 6 months, we've compared 6 months prior to being enrolled in our clinic to 6 months after. And just within that 6 month time frame, we were able to, save an estimate of about $1 million.
Wow. How many patients?
And that's 54 people.
Wow.
Mm-hmm. Yeah.
Pretty big number.
Yeah, we were astounded by that. And And that's, not taking into consideration everybody. So for people that didn't have any medical care prior to, understandably their costs were higher at the beginning. But even kind of taking into account everybody, we still found about a $300,000 savings for, all of our population. And that's closer to about 200 people at the time that we had this data.
Okay, so you went, because there is this thing about regression to the mean if you actually get people during the, kind of sickest point, but you went whole population. So you're measuring both people who were getting sicker and the people who were getting better. Even then you netted $300,000 basically, right? Okay, so that's, it's pretty hard to gain that. What about other measures that we have of population health? I mean, hemoglobin A1Cs or, actual weight loss. Are there other markers that the program's actually working in the way it's intended?
Absolutely. So when we originally started our grant, we were funded by SAMHSA's Primary and Behavioral Healthcare Integration Initiative. And because of being a part of a grant, we had a number of different measures that we were tracking periodically over time. So we tracked individuals' BMI, their A1C, their blood pressure, their lipids, their breath CO, which is a measure of kind of the amount of carbon dioxide for smokers. Your lungs, and we found considerable gains over all of those indicators. So for example, for our BMI population, and we came in with a fairly sick population at baseline. So a number of them were already in the at-risk range. We had over half of them show improvement in their BMI after being enrolled in our program for a year. For blood pressure, we had 70% show improvement in their hypertension, their blood pressure ranges. So we've got lots and lots of data just from being a part of the grant, and we're hoping to get our annual final report out soon that we can publish and cast more widely for folks, because there's a lot of great stuff in there we want to get out.
Very cool.
Yeah.
Steph, I can't see my chat box. Do we have questions from the audience?
Not yet, Jay.
Okay. So I'll just keep throwing and cut in anytime, Steph, if they send stuff in. So what's the downside? Why wouldn't I want to do this? I mean, it sounds like, one, providers are happier because they feel like they can actually do something about some of the kind of base causes. Costs come down, population health has improved. What difficulties have you run into, or what problems have you found that that you didn't know you were going to have?
I think one challenge that we've identified, it's not necessarily a challenge, it's just it makes sense to do this work, and the clinicians on both ends feel like that is value added to their patients, to their practice. But the nitty gritty is often what the challenge is. So having separate EMRs that don't talk to each other yet, that creates kind of things that then we do workarounds on. And we have to integrate, it's not just at the ground level where we integrate, it's with our financing, it's with billing, it's with our HR and our credentialing and onboarding process, it's with, coding and documentation, and all levels of both organizations really need to be working together and together pretty well. So that's not necessarily a challenge, it's just a lot of people kind of investing their time and energy to do the right thing.
Yeah. So it sounds like it's still kind of a stage of evolution. I mean, you're not completely one organization yet, right? I mean, I still document on my thing, you still document on your thing, I have to send you a note, all that stuff, rather than us being able to look into a single record which has everything from both sides, right?
Yep, right, yeah, exactly.
Okay. Hey, Jay, I'm going to go ahead and jump in. We've got a couple of questions.
Okay, go for it.
It's nicely topical. Dana writes, what EHR are you using? And how did it need to be customized for this implementation?
Yeah, great question.
Yeah. On our side, on the mental health center side, we use an EMR called MindLink. It's out of Duke. And our primary care partner, MCPN, uses Centricity. I don't know that we've had to make any modifications to them to be able to do the work, largely because it's really hard to do that. but we're working on it, and that's definitely our hope down the road, is that we'll have the ability to do some modifications to be able to use like a continuity of care document or a way to kind of use flat files to exchange information more seamlessly. We're not quite there yet.
Cool.
All right, we have another question from Amy. She asks, where does funding come from for the personal trainer?
Can you talk about funding in general? I mean, you said there was SAMHSA grant funded. How are things sustained going forward?
Well, the SAMHSA grant ended at the end of January, and we started a grant through the Colorado Department of Public Health and Environment this past October, which supports intensive focus on hypertension. So we now have a project where we're really working with folks on managing that. We give them home blood pressure monitoring equipment, and obviously our weight loss and smoking cessation programming and cooking classes that we're offering goes into that. So, you know, as we're talking, a lot of the workarounds that we have to do take manpower, and these people do cost some money while we are saving the healthcare system some money. So hopefully our healthcare system will shift to support this and our technology systems.
Okay. So you're hoping basically for new payment models, which will actually incorporate the additional.
Yeah, and we are able to count some of our services under capitated billing structures here in Colorado as well.
Oh,
So we do that.
So you do have some capitated. Is that right?
Say that again?
Capitation. You do
Yeah.
have some member per month payment.
Yeah.
These kinds of services make all kinds of sense, I think.
Yeah, and in our final report, we're going to be looking more closely at it. Can be hard to calculate the income from a capitation system. So we're in process though, because we may be breaking even. We could be.
And in terms of the personal trainer, our mental health center has kind of just decided to invest in supporting that position to help, the health and wellness of our clients. So that's just an FTE that our center is assuming the cost of.
Okay, so there isn't a specific grant for the personal trainer, to address Amy's question. I mean, essentially you say, here's all the money that's coming in. Basically, we need this kind of personnel or this kind of service, and so we basically make the numbers work. But there isn't a dedicated funding stream for the personal trainer per se, right?
Right.
Yeah. Okay. Very good. Anything else in the chat box, Steph?
Yeah, there is a question from Barbara. And hey, Jay, can you move a little closer to your microphone?
Oh yeah. Sorry about that.
Sorry. Barbara asks, she says, in light of your wonderful outcome data, are other mental health centers around the country trying to replicate your program?
Good question. So actually we have benefited from being in the SAMHSA funding the PBHCI project, and that is a national grant. I think they're in their 7th cohort, potentially, maybe even 8th.
Yeah, I think maybe 8th, yeah.
And all of those endeavors are really doing kind of similar projects to what we're doing, kind of funding and finding the need and funding clinics to put in bidirectional care clinics. In Colorado, we have a number of other mental health centers that are doing similar kinds of things, and so we've actually been kind of not meeting regularly recently, but in the past, every quarter or so, we'll meet and just share kind of common challenges and successes and, piggyback on each other's ideas. So we're all kind of learning together, which is really cool.
So last question before we wrap up. If you had to start all over again and it was 2013, what would you do differently?
That's a good one.
That is a good question. I think something that I always think of is, as we've been discussing, such a big piece of the work is really paying attention to and nurturing our relationship with our medical partner. In the beginning, I think it would have been good to make sure that we really had dialed in scheduled meetings from the beginning for all departments at all levels, and really having frequent, candid conversations about vision and what everybody's thinking the path is to that vision. So often there ends up being oh, what just happened? And we kind of
Yeah.
come together and work it out. So maybe more proactively doing that.
That really says something to me, because it sounds like you were very mindful of that in the beginning anyway, but it sounds like you can never have too much of that relationship building, especially when you're dealing with separate cultures. Is that right?
Yeah,
Exactly,
totally.
exactly, yes. Yep.
Okay. All right, you guys were great. Thank you so much for joining us today. It's been a wonderful discussion. Thanks to everybody who's on the webinar who joined us as well. The recording of the discussion will be shared via social media and will be on the Civic website on Monday. So please join us next time on Friday, June 23rd, when we chat with Paul Staley from Centura's Accountable Care Organization about their work. Thanks again to everybody who joined us, and have a great weekend. Bye-bye.